What's up, Ninja Nerds? In this video today, we're going to be talking about anxiolytics and hypnotics. Before we get started really into the lecture, if you guys do like this video, it makes sense, it helps you guys to really kind of overcome this challenging topic, because it really can be. Please support us. The best way that you can do this is by hitting that like button, commenting down in the comment section, and also subscribing. Also, if you guys do want some notes and some illustrations that are really great, help you guys to truly understand the topic, go down in the description box below. We have a link to our website where we have some awesome notes and illustrations. But let's get into it. Let's talk about anxiolytics and hypnotics. So when we talk about this, we really have to get down to the kind of basic pathophysiology. And when I mean basic, I really mean basic. I don't want to get too crazy. I just want you to understand what anxiety truly is, right? So it's this kind of sense of unpleasant sensation of fear or apprehension that can present with physical symptoms, right? And we'll talk about that. Oftentimes it's like tachycardia, palpitations, hypertension, maybe a little bit of breathing fast, some tremors, some diaphoresis. Those are common features of anxiety. Well, anxiety, really when it comes down to it, is due to some type of limbic system dysfunction, right? You know, there's so many nuclei involved in our limbic system. We're not going to go through that aspect, but what I do want you to know is that the limbic system is the one responsible for our emotional aspects of our body, right? So it's the emotional component of our brain. It's also involved in memories as well. But there's some degree of limbic system dysfunction here. And that's really what it's coming down to in this particular disease. Now, if we dig into it a little bit more, right? So the limbic system is obviously important for memory. It's important for emotions and our behaviors. So if there's some dysfunction of the limbic system, it's not out of this world to think that it can precipitate anxiety, which is a type of emotion, an unpleasant sensation of fear and apprehension. So what causes the limbic system dysfunction is really the question, right? Well, there's some particular neurons that are involved in the limbic system that actually release very specific types of neurotransmitters. You know what those neurotransmitters are? The two neurotransmitters that are integral to the function of the limbic system is going to be GABA. So GABA is a very important one here. This is also referred to as gamma-aminobutyric acid. And the other one, believe it or not to a degree, is also called serotonin. We also write this as 5-hydroxytryptamine. These definitely have an influence on the limbic system. And so whenever GABA is present and whenever serotonin is present, what this generally will do is this will help to be able to maintain a good control of the limbic system. But what if, for some reason, there's decreasing GABA activity or there's decreasing serotonin activity? If there's decreasing GABA activity or decreasing serotonin activity, this really kind of causes a lot of dysfunction of the limbic system. When the limbic system becomes dysfunctional, there's an excessive excitation of the sympathetic nervous system. So now the sympathetic nervous system becomes hyperactive because of these low transmitters. So if these neurotransmitters are really, really low, it causes the limbic system to now become dysfunctional. That then hyperstimulates the sympathetic nervous system. The sympathetic nervous system then has the ability to go and stimulate multiple different organ systems, like the heart. And here it increases your heart rate. It increases your blood pressure. It acts on the muscle spindles and causes tremors. It acts on your sweat glands and causes diaphoresis. It also acts on your respiratory system, and maybe it kind of increases your respiratory rate. All of these things are physical symptoms or features of anxiety. And that's really the kind of the crux of this disease. So anxiety is limbic system dysfunction categorized by low amounts of GABA activity and low amounts of serotonin activity. That leads to dysfunction of the limbic system and then hyperactivates the sympathetic nervous system, which leads to all of this type of fear and apprehension response. Now, the basic thing that I want you to take away from this is that anxiety is classified by low levels of GABA and low levels of serotonin. And that's really what it comes down to in this particular disease. And to give you kind of an understanding of this, we'll kind of have a basic diagram here. Here's going to be a neuron of the limbic system, right? Here's the neuron of the limbic system. And what it'll do is it'll signal to your sympathetic nervous system. We have neurons such as serotonin neurons, and we have neurons called GABAergic neurons. And what happens is this one releases GABA. GABA is an inhibitory neurotransmitter, so it's supposed to inhibit this limbic system neuron, which would inhibit it from actually causing a lot of sympathetic cascade. But if you have low levels of GABA, what's going to happen? Low levels of GABA will no longer be able to inhibit this. And so this inhibition factor is gone. And then you increase the sympathetic nervous system. The other one is your serotonin. This is 5-hydroxytryptamine. When there's low levels of serotonin, it no longer is able to stimulate these GABAergic neurons. So normally it should be able to stimulate these GABAergic neurons, and then GABA would inhibit the actual limbic system from causing a sympathetic response. But if you have low levels of serotonin, you're not going to be able to stimulate GABA. GABA will no longer be able to inhibit the limbic system activity, and the sympathetic cascade will increase. That's the basic pathophys. So this is the big things that I really want you to know for anxiety. Now, let's now talk about insomnia, because now we're going to talk about hypnotic agents. So anxiety, we're going to use drugs that are going to try to increase GABA and increase serotonin. They'll have anxiolytic effects. They'll cut the anxiety. Or, in this situation, insomnia, the inability to sleep, we're going to talk about drugs that are going to be hypnotic agents. But first, we have to understand the pathophysiology of insomnia. All right, my friends, so insomnia is the inability to fall asleep or maintain sleep, right? And why is that? Well, there's a couple different structures that are really involved in this, and really to come down to the most simplistic aspect, you have some structures like the pineal gland, right? So the pineal gland is a really, really important one. It releases a particular hormone called melatonin. So that's one particular structure that's involved in sleep cycles. The other one is your hypothalamus, and there's many different nuclei of the hypothalamus. Okay, many different nuclei of the hypothalamus. And then the last structure here that's really, really important is called your reticular formation. And there are so many different nuclei that are involved in the reticular formation. But there is some type of dysfunction between the communication in these particular structures. So what's really going on is that there is some type of disconnection. Usually these structures should talk to one another, but there is some type of abnormality here where they're not actually communicating properly with one another. Let's dig into that a little bit more. So what I actually want to do is I want to take some of these structures of the pineal gland, the hypothalamus, and the reticular formation, zoom in on them, and talk about some of the neurotransmitters that it's involved and how they interact between these different structures, and what's the real pathophysiology, or this disconnect, if you will. So the first component is the pineal gland. Normally, when the pineal gland is activated, usually when a patient's exposed to dark lights, they should produce melatonin. That's the first particular neurotransmitter that I want you guys to know, or hormone. So this first one is going to be called melatonin. Now, when a person is in dark light, melatonin should be released. And what melatonin should do is it acts on what's called melatonin 1 and melatonin 2 receptors that are present on the structure called the suprachiasmatic nucleus. This is a really important structure that regulates our circadian rhythm. It's found in the hypothalamus. What melatonin acts on the suprachiasmatic nucleus, it should naturally work to inhibit the suprachiasmatic nucleus, turn him off. So when he's off, that's really when we want to try to do what? Go to sleep. So naturally what should happen is this should normally do what? This should inhibit the suprachiasmatic nucleus. When the suprachiasmatic nucleus is inhibited, it no longer will cause this inactivation of this structure. So this is one of the structures of the hypothalamus that's really, really important. It's called the ventrolateral preoptic nucleus. I'm going to abbreviate that to VLPO. It's found in the hypothalamus. When the suprachiasmatic nucleus is inhibited, what it generally will do is it'll activate the VLPO. So it'll stimulate the VLPO. It should stimulate it. Now the VLPO has two things that it does. One is when it's active, it should promote sleep. It should promote sleep. It wants to promote sleep. But in order for it to promote sleep, it has to suppress arousal or wakefulness. So how does it do that? So then what happens is the VLPO secretes very specific types of neurotransmitters that suppress all these different nuclei. So you have what's called the tuberomammillary nucleus, the lateral hypothalamic nucleus, and so many nuclei of the hypothalamus. The reticular formation. So you have the reticular formation nuclei and the posterior hypothalamic nuclei. What happens is the ventrolateral preoptic nucleus releases something called gamma-aminobutyric acid. And what gamma-aminobutyric acid should do I want you to think about your reticular formation in your posterior hypothalamus. is it should inhibit them. If it inhibits them, it should then inhibit arousal and wakefulness. So now the VLPO is activated because of melatonin, right? Because melatonin inhibits the suprachiasmatic nucleus, which activates the VLPO. VLPO promotes sleep, and then it suppresses arousal and wakefulness by releasing GABA to inhibit the reticular formation in the posterior hypothalamus. That's the really cool concept. Now, at the same time, whenever a person is having insomnia, right? What you see in this particular process is that you wouldn't want to promote sleep. You wouldn't want to promote sleep. You'd want to promote arousal and wakefulness if they have insomnia. So imagine now I drop my melatonin levels. If I drop my melatonin levels, will I be able to inhibit the suprachiasmatic nucleus? No. So I will no longer be able to inhibit this bad boy. If I can't inhibit him, will I be able to activate the VLPO? No, so I won't be able to activate the VLPO. If the VLPO is activated, will it be able to promote sleep? No. And if he can't promote sleep, can he then suppress the reticular formation in the posterior hypothalamus? No, he can't suppress it. And therefore, he can't suppress arousal and wakefulness. That's one particular problem. So one part of this disease process, insomnia, is that the patient may have low levels of what? Melatonin. Now, let's think about the next aspect here. What if we go to the second part here? So get rid of melatonin. Let's say that the VLPO now is in this state where it's supposed to be active. When it's active, it wants to promote sleep. So it'll do that, right? But in order for it to do that, it has to suppress the posterior hypothalamus and the reticular formation. So it releases GABA. What if we had low levels of GABA? Because GABA is essential for being able to suppress the reticular formation and suppress the posterior hypothalamus. If we have low GABA levels, will we be able to suppress this anymore? No. So you can't suppress it, you can't suppress arousal, and you won't be able to suppress the arousal and wakefulness, and you won't be able to promote sleep. So there's another particular problem, is low levels of GABA. So if you have low levels of GABA and low levels of melatonin, the reticular formation will then be hyperactive and the VLPO will be inactive. There's another particular concept here. The reticular formation releases chemicals that are supposed to naturally inactivate the VLPO. And if you inactivate the VLPO, it would inhibit sleep, right? It would inhibit sleep. Now, what are these chemicals that the posterior hypothalamus and reticular formation releases to suppress the VLPO? Those chemicals are called orexin and histamine. So these chemicals naturally are going to suppress the VLPO, which would then suppress sleep. If you inhibit this, are you going to be able to promote sleep? No. If you inhibit this, is the VLPO going to be able to inhibit the reticular formation? No. So the reticular formation will be active and then trigger arousal and wakefulness. So these would be the bad boys. If they're in higher levels, they're going to suppress the VLPO, suppress sleep, and keep the reticular formation activated to promote arousal and wakefulness. That's terrible. But that is another pathophysiological concept here, is that you can have high orexins and high histamine levels. So that's the other pathophysiological process here. So when it comes down to it, the big thing that I want you to take away from this is that whenever you have low melatonin levels and low GABA, this will cause insomnia. High orexin levels and high histamine levels, this will also cause insomnia. And the basic concept behind this is that if this is all basically happening, what all of these things are doing is they are inhibiting the VLPO, which is going to inhibit sleep, and these are all going to stimulate the reticular formation, and that is going to stimulate arousal or wakefulness, and again, inhibit sleep. And that is the concept here. So if we come up with hypnotics, the hypnotics should be able to increase melatonin, increase GABA, decrease orexin, and decrease histamines. Whereas with anxiolytics, we need to come up with drugs that increase GABA and increase serotonin. So now let's talk about those drugs that actually act as an anxiolytic and the drugs that act as hypnotics in patients who have anxiety or insomnia. All right, my friends, so now anxiolytics, we got to give the drugs now that are going to be able to help these patients who are having anxiety. So When we think about this, let's talk about two things. One is the mechanism. So really, how are these drugs actually helping to increase GABA or increase serotonin? Because that was the whole goal, right? And then what are some of those drugs? What are some of the names of those drugs that we're actually going to talk about? So first thing for anxiolysis with mechanism here is, again, we have two particular neurotransmitters here. One is this neurotransmitter right here, my friends. So this is a neuron that's going to be releasing something called 5-hydroxytryptamine. That's also known as serotonin. So this is also referred to as serotonin. Now, serotonin is low in anxiety, but it's also low in another disorder called depression. And depression and anxiety often sometimes are good cousins or friends of one another, and so they often coexist. Whenever there's low levels of serotonin, which we said that was the process of anxiety, is there's low levels of serotonin. What was the problem with that? Well, serotonin is naturally supposed to bind onto this receptor here. You see this receptor on this blue neuron? This is called a 5-hydroxytryptamine receptor, a serotonin receptor. When serotonin binds onto this receptor, it's supposed to stimulate, so it should cause like a cationic influx and stimulate this neuron. This neuron releases a neurotransmitter called GABA. And GABA is supposed to naturally do what? Inhibit this limbic system neuron. So naturally what it's supposed to do is it should work to bind onto this particular receptor. So this is GABA. GABA should bind into that little pocket there, this little receptor here. You see this receptor here? This is a really important receptor. This receptor here is called the GABA A receptor. Very, very important receptor. When GABA binds onto this little pocket here, and we'll talk about that in a little bit, it opens up this channel to allow for chloride ions to flow in. These are negative ions. When negative ions flow into this particular neuron, what it's supposed to do is it causes the cell to become super negative. You know what we call that? When the cell becomes super negative, it causes hyperpolarization. Hyperpolarization basically makes the cell super negative, and that should decrease the action potentials. So then the limbic system neuron shouldn't be firing excessively. And so because of that, there should be a decreased sympathetic effect. So decreased fear, apprehension, tachycardia, hypertension, respiratory rates aren't going up as much, you aren't having tremors or diaphoresis as much, right? And so that's really what the benefit of GABA would be. But if you're having low serotonin, you're not going to tell these neurons to make GABA. And so because of that, the GABA would be low. The GABA would be low. GABA wouldn't be able to work on this receptor. It wouldn't be able to allow for chloride ion influx to cause hyperpolarization to decrease action potentials. So that's really what it comes down to in this particular process. So what if I came up with a drug that specifically worked? One of these drugs, I'm going to use a drug, and what I'm going to do is I'm going to inhibit that particular receptor right there, that little protein there. You know what that protein's supposed to do? When serotonin is done exerting its function, it's supposed to go back in to the axon, right? It's supposed to go back into the axon. But then that lowers the serotonin level in the synapse. What if I came up with a drug that inhibited that serotonin reuptake protein? So I'm going to inhibit this reuptake protein, this reuptake mechanism. I'm going to inhibit that. What does that do to the serotonin now in the synapse? If I don't take it back into the axon, it's going to stay here now. So what happens to the serotonin levels? They go up. If serotonin levels go up now, then I'm going to be able to increase the stimulation of these GABAergic neurons. Then they're going to release a lot of GABA. If they release a lot of GABA, then GABA will be able to inhibit these particular neurons by causing chloride ion influx, because it'll stimulate this GABA A receptor. It'll increase hyperpolarization. And if you do that, it'll really, really decrease the action potentials and decrease the sympathetic response. That's a really cool concept. Another thing is if I had a drug that actually had the ability to bind, so let's say I have another drug and it directly binds to this receptor. So it stimulates the receptor, and that increases the positive ions, increases GABA, increases the binding of GABA receptor, increases hyperpolarization, decreases action potential, and decreases the sympathetic or anxiety response. That'd be another benefit too. What are these drugs that can increase serotonin by inhibiting reuptake, or drugs that can bind directly to the serotonin receptor? These would include your SSRIs. So your selective serotonin reuptake inhibitors, they'll inhibit the reuptake of serotonin. There's another group which actually blocks the reuptake of serotonin and norepinephrine, but they block the reuptake of serotonin. So these are two drug categories that are going to do what? Inhibit reuptake. So these two here, these one specifically here is going to inhibit reuptake, and this one here is going to inhibit reuptake. And that's how it'll increase the serotonin activity. These drugs include which ones? So SSRIs, I want you to remember escitalopram. Citrulline is another particular big one here. Paroxetine is another one as well. So these are some of the drugs that I want you guys to remember. The SNRIs are going to be things like venlafaxine, and duloxetine. These are going to be some of the drugs that we can utilize in anxiety, but more specifically, we'll talk about later, chronic anxiety. Because patients who have chronic anxiety likely have some degree of associated depression, and these drugs have been shown to be more effective and less abuse potential than the next drug category that we'll talk about, the ones that affect GABA. And the last one is buspirone, and buspirones have actually been shown to directly stimulate the 5-HT receptor. And this is going to be the name of that drug, buspirone. There is no specific category, it's just buspirone. There is even some thought that it actually may affect some of the dopamine receptors as well, but for right now, keep it simple. We're going to focus on serotonin. Okay, so that's one set of drugs. SSRIs, SNRIs, both inhibit the reuptake of serotonin, increase the serotonin in the synapse, or buspirone, which binds onto the serotonin receptor. That will increase the inhibition of the limbic system and inhibit the sympathetic response. What if I avoid the serotonin now and I just focus on GABA? The problem with GABA was low. So GABA wasn't actually being either released enough or it wasn't acting on this receptor properly. Well, what if I gave drugs that either increased some way, shape, or form the GABA activity? What if I gave a drug that specifically hit right here? It stimulated this particular receptor. So it stimulated the GABA-A receptor. It bound onto the GABA-A receptor and enhanced the activity of the GABA-A receptor. So GABA doesn't even have to be present. This drug will bind onto that little socket there on the GABA-A receptor, open it up. That'll increase chloride ion influx. That'll increase hyperpolarization. That'll decrease the action potentials of the limbic system and suppress the sympathetic anxiety and fear response. That's a pretty cool concept. So we need to give drugs that are going to increase GABA activity. We specifically call these ones, just so you know, these are actually called GABA agonists. That's really what we should call them. So they're not increasing the levels of GABA, but they're kind of acting like GABA. And so they have the same effect. So that's really, really important, because when you think about this, if we were to actually take this GABA-A receptor and zoom in on it a little bit, here it is. It's a pentameric type of protein. And it's made up of different subunits. So you have one of the subunits, a gamma subunit. You have a beta 1 subunit. You have a beta 2 subunit. You have a alpha 1 subunit and an alpha 2 subunit. Out of all of these, the one that's actually been shown to be most specific to actually inhibiting the limbic system neurons is the alpha 2. Very, very important. So the alpha 2 is the one specific subunit that these GABA agonists actually bind to. So when GABA agonists actually help to open up this GABA-A receptor, which of the actual sites do they have to bind onto in order to activate this channel and cause chloride ions to flow into the cell? They have to bind onto the alpha 2 subunit. That's very, very important. So again, I want to write it down so that you understand here. It's going to bind onto the alpha 2 subunit of the GABA-A receptor. What are these drugs that have this GABA-A agonistic activity, or the GABA activity that's agonistic like? These are going to be barbiturates and benzodiazepines. But here's the thing. I don't even want to waste any time. We don't even use barbiturates anymore for anxiolysis. The reason why is there's just too much toxicity with this drug. there's so much more risk than there is benefit to the treatment of anxiolysis. We use barbiturates more specifically in other things. So seizure activity, anesthesia, or maybe even inducing a coma to reduce ICP. But it is not an effective agent for anxiolysis because of the adverse effects of it. So what we may utilize instead, because there's not as many adverse effects as severe as barbiturates, is benzodiazepines. Benzodiazepines, there's different types. So we can use them based upon their half-life. So if something acts very, very quickly and it gets metabolized and it gets removed from the body or excreted, it's cleared quickly, its half-life is very short. So that would be good drugs that maybe you don't want to have it last as long. All right? So short-acting drugs that I want you guys to remember here is going to be a couple. One is called midazolam. Midazolam is a very commonly utilized one. Triazolam. Triazolam is another one. Intermediate, there's a bunch of these. Lorazepam is one. Oxazepam. Alprazolam. A couple more just to mention is Temazepam. Then you have your long-acting. And there's a bunch for these one as well. So Diazepam is one. Chlorodiazepoxide. There's a bunch of these different types of drugs, right? But with that being said, and then there's another one that's actually important to remember, clonazepam. Clonazepam is another one, clonazepam. But out of all of these, the ones that we've actually seen benefit to actually treating anxiety, having an anxiolytic effect, is the ones that I'm going to circle. Lorazepam is one. Oxazepam is one. Alprazolam is one. Diazepam is one. And clonazepam is one. The reason you would pick one over the other is dependent upon how long you'd like this to act. So if you gave something like diazepam or clonazepam, it's going to have a longer anxiolytic effect. Whereas if you give something like lorazepam, oxazepam, or alprazolam, they're going to be more intermediate acting, okay? So that's an important concept to remember. But again, to take away from this, anxiolytic drugs are drugs that are going to increase serotonin activity. They either inhibit the reuptake, SSRI, SNRI, or they activate the serotonin receptor, buspirone. Or they increase similarity of the GABA activity. In other words, they stimulate the GABA-A receptor. They act as an agonist. And that will, by binding to the alpha-2 subunit of that receptor, increase chloride influx and inhibit the limbic system dysfunction. By doing that, we can use two agonist drugs. One is barbiturates, which we don't use as much because they're so toxic, and benzodiazepines. The reason why, if we were to really add on to the barbiturates, is barbiturates, when they bind onto the GABA-A receptor, they increase the duration of chloride channel opening. And that is a really scary thing, because if these things stay open, you can really inhibit a lot of different neurons. So that's a really, really important concept, is they actually increase the duration. Benzodiazepines, on the other hand, increase the frequency. So they increase the frequency of chloride channel opening. And that's a really important kind of like takeaway point for this particular process here for your GABA-A agonists, okay? All right, that covers our drugs that are going to be utilized for anxiolysis. So again, a quick recap: SSRIs, SNRIs, for those that are increasing the serotonin by inhibiting reuptake. This includes escitalopram, paroxetine, citrulline, or your SNRIs, venlafaxine, duloxetine, or you can have buspirone, which is a direct serotonin type of agonist. You can also act to increase the GABA-A activity or GABA activity by binding to the GABA-A receptor, acting as an agonist. The drugs that increase GABA activity by acting as an agonist is barbiturates. Don't use them because of the toxicity. The toxicity is due to a high duration of chloride channel opening. Benzodiazepines are more beneficial and not as many toxic effects because they only increase the frequency of chloride ion channels. And this includes the short-acting triazolam, midazolam, intermediate acting, which would be lorazepam, oxazepam, temazepam, as well as alprazolam, and then the last one is the long-acting diazepam, chlordiazepoxide, and clonazepam. With those, these are the more particularly utilized ones for anxiolysis. All right, now let's talk about the drugs for hypnosis. In other words, you want to treat insomnia. All right, guys, so when we talk about hypnosis, you're trying to induce sleep and maintain sleep, right? So the mechanism behind this is that the pineal gland, right, releases melatonin. In this disease process, there's low melatonin. So let me kind of come up with a way to increase melatonin. So that's one particular mechanism, is I want to give drugs that are going to specifically act on the melatonin receptor. So you remember how there was the melatonin 1 and the melatonin 2 receptors? What if I gave a drug that acts as an agonist to melatonin and it stimulates this receptor? That would basically be as if melatonin was present. Because in this disease, one of the problems is that we have low melatonin, right? So one of the problems is low melatonin. If I work to increase the effect of melatonin, wouldn't a melatonin agonist be the same as kind of increasing melatonin? Yes, because it's going to activate those receptors, and that's going to inhibit the suprachiasmatic nucleus, which stimulates the VLPO, which stimulates sleep, and then releases GABA to inhibit the reticular formation in the posterior hypothalamus, which would then inhibit arousal and wakefulness. We know that. So that's one way. And what are some of the drugs that help to be able to increase melatonin by acting as a melatonin agonist? This includes Ramelteon and Tasimelteon. So Ramelteon. Okay. The next thing is, let's come to the GABA. We said GABA was another particular problem, right? That GABA was low in this particular pathophysiology. So GABA was low, and if GABA was low, what we knew is that GABA, if it was in the lower amounts, it wasn't inhibiting the posterior hypothalamus, it wasn't inhibiting the reticular formation. And so if it wasn't inhibiting the reticular formation, it wouldn't be able to inhibit arousal and wakefulness. And on top of that, if you couldn't inhibit the reticular formation would keep suppressing the VLPO so that you don't sleep. So what if I come up with a way to have some type of drug to bind onto the GABA-A receptor? So what if I stimulate the GABA-A receptor? I give a drug that acts as an agonist to GABA, and it stimulates this particular receptor. If it stimulates this receptor, it's going to inhibit the reticular formation. If you inhibit the reticular formation, you'll inhibit arousal and wakefulness. So now this patient won't be able to stay awake. On top of that, if you inhibit the reticular formation, it can't release those factors that are supposed to. Naturally, it's supposed to inhibit the VLPO, right? Because it releases things like orexin and it releases things like histamines. But if you inhibit the reticular formation, it can't release those chemicals to inhibit the VLPO. So the VLPO stays active and promotes sleep. That's drugs that are going to increase GABA. We already talked about these. Here's the difference though. Here's the big difference. On this part here, for where the GABA-A receptors bind to, I'm going to put it in a little note here. It's the alpha 1 subunit. So I'm going to put, this is the alpha 1 subunit. I'm just going to put alpha 1 here. So it's alpha 2 for anxiolysis, which is in the limbic system, alpha 1 on the reticular formation that's going to induce hypnosis. That's really important because now I can add a third drug to drugs that actually increase that GABA activity. Before it was barbiturates, right? We don't use these, right? Because of increased toxicity. We do not use these for hypnosis, okay? And then we have benzodiazepines. These will actually do what? They'll bind to the alpha 1 and help to be able to increase chloride influx and cause the reticular formation to be suppressed. So if the reticular formation is suppressed, you won't be able to stay awake, you'll fall asleep. And this includes 2 particular drugs in the benzodiazepines. So there was short-acting, intermediate-acting, and long-acting, right? Out of those, particularly Temazepam and Lorazepam are the most specific ones that I want you to remember. So Temazepam, and Lorazepam are the most commonly utilized benzodiazepines for actually helping to induce hypnosis by inhibiting the reticular formation. That adds the last drug. So barbiturates would also do the alpha 1, but we don't use these. And then the Z drugs. Z drugs also bind to the alpha 1 subunit, but they don't bind onto the alpha 2 subunit. So they have, so if I were to kind of put a thing here, they have positive alpha 1, but they do not have alpha 2 activity. This one has alpha 1 and it has alpha 2 activity. This one has alpha 1 and it has alpha 2 activity. You see the difference there? What are some of the Z drugs that only induce hypnosis but do not provide anxiolysis? This includes Zolpidem, Zaleplon, and Eszopiclone. These are going to be your Z drugs. And again, they do this by binding onto the GABA-A receptor and promoting chloride ion influx, which will cause hyperpolarization, decrease the action potentials, and decrease the activation of the reticular formation. So the reticular formation will be suppressed, you won't be able to stay awake, you'll then promote sleep. Beautiful. Okay, the next concept is that we had another problem here, which was that when the reticular formation is active, it's giving drugs like, it's secreting things like orexin, and it's secreting things like histamine. And histamine and orexin are supposed to naturally do what? Inhibit the VLPO, right? So they're naturally what they would do is they would inhibit the VLPO. And then you wouldn't be able to promote sleep, right? Now, if I give a drug that basically will block, it'll act as an antagonist. So I will give an antagonist to orexin or an antagonist to histamine. Then I'll no longer be able to allow for these drugs to inhibit the VLPO. So now the VLPO will no longer be inhibited. Instead, it'll be stimulated, it'll be released from inhibition, and it'll be able to promote sleep. If it can promote sleep, it'll then be able to suppress the reticular formation and prevent the further release of more orexins and histamines. But I should give drugs that can act as antagonists to block orexin and histamine so it doesn't shut down the VLPO, because I need him active to sleep. So I need to give drugs that will decrease orexin. So naturally, the problem in this pathophysiology is that there's too much orexin and there's too much histamine. Whoops, let's do this in the blue color. So there's too much orexin or there's too much histamine in the pathophysiology. So what I need to do is I need to give drugs that are going to block that effect. They're going to block this effect. So now you're no longer able to inhibit the VLPO. You keep the VLPO activated now. What are the drugs that help to block orexin and block histamines? So the drugs that actually decrease orexin is going to be something called suvorexant, and it's a newer drug. We don't know a ton about this drug, but it is a newer type of drug. The other ones are the drugs that decrease the histamine, so they block the increase in histamine. They block the histamine from binding to the VLPO. There's so many different types. Some of you may have used this before, but diphenhydramine, right? Diphenhydramine is a very commonly utilized antihistamine. It's Benadryl. And Benadryl will actually be able to promote sedation. If you're using it for like an allergic reaction, you may have noticed that it also can produce some residual sedation. Because the histamine, right, when it hits the VLPO, it keeps the VLPO inactive, so you can't sleep, right? But if you give diphenhydramine, it blocks the histamine from binding to the VLPO. Now the VLPO is actually active and it promotes sleep. So this would be, again, something like diphenhydramine. Diphenhydramine. And this is more of an adverse effect, unfortunately, of the drug. And the same concept, you have antidepressants. And these antidepressants are interesting in the sense that they can increase serotonin activity, but they can also decrease histamine activity. And that's really cool. And what are some of these drugs? So there's a bunch of them. One is called Doxepin, and Doxepin is actually what's referred to as a tricyclic antidepressant, but it has antihistamine properties. Another one is called mirtazapine, and another one is called trazodone, and these are these types of atypical antidepressants. But these are drugs that also have the ability to block the histamine from binding to the VLPO. And if the VLPO doesn't have histamine bind to it, it's then active, it can promote sleep and suppress the reticular formation. And that's the basic concept. In these particular problems, these things are all doing what? They're inhibiting the VLPO so that you don't sleep. And they're stimulating the reticular formation so that you stay awake. If you give drugs that help to do the opposite, increase melatonin, increase GABA, decrease orexin, decrease histamines, this will now do what? This will help to inhibit the reticular formation and stimulate the VLPO. And that is the goal here, is to keep the VLPO active and the reticular formation off. And by doing that, this will all promote sleep. And that is the ultimate goal here. All right, my friends, that covers all the mechanism of anxiolytics and hypnotics and all the drugs that are included in that. The next thing is I want to take a quick approach. So when a patient has anxiety, how do I know which drug to pick? Because there was a bunch. And if they have insomnia, how do I know which drug to pick? Because there's so much. So we'll talk about that briefly. All right, my friends, so now let's talk about quickly and approach this. So if a patient has anxiety, right, acute anxiety, generally benzodiazepines are going to be the best fit for that patient during that acute anxiety attack. They work very, very quickly. And so they're really going to be the best particular drug option for a patient who is having acute anxiety, right? So when you have acute anxiety, benzodiazepines are going to be the go-to, okay? And again, just as a reminder, what were some of those drugs? This would be the Alprazolam. Alprazolam is a great one, very commonly utilized one. Another one is Clonazepam. Another one is going to be Diazepam. Another one is going to be Lorazepam. Another one is going to be Oxazepam. All of these can be utilized in a patient who has acute anxiety. Now here's the downside. These drugs have the ability to produce abuse potential. They're controlled substances, so they have addiction potential. So one of the downsides to these drugs is that they can cause abuse. So we don't want to keep patients on these for a super long period of time. So the preferred action of these drugs is we prefer for these to be a PRN basis, only use when you have a patient who has really, really bad anxiety and very specific types of disorders, and it's for that acute kind of breakthrough anxiety. When you have a patient with chronic anxiety, and this is really when it comes down to like diseases such as really generalized anxiety disorder, social anxiety disorder, panic attack disorder, phobias, etc., then these patients may require something a little bit more long-term. And in those particular scenarios, for the long-term basis, benzodiazepines aren't going to be the best. And so what we prefer is to give drugs that increase serotonin. So this would be your SSRI or an SNRI, right? And then for the chronic anxiety, you can do a PRN benzodiazepine. And that's generally how we would go about this. Another thing is, let's say that again, you do the PRN benzodiazepine, but you're still worried that the patient has a high risk of abuse potential. Take that into consideration in their history. An alternative to a PRN benzodiazepine is something like buspirone. So buspirone may be a decent alternative with very little likelihood of abuse potential. So this is generally how you would go about this. Acute anxiety, you start off with benzodiazepines just for the breakthrough, okay? Buspirone will not be good for acute anxiety, okay? This is good for the breakthrough. The other thing is SSRIs and SNRIs, you know how long they take? These puppies can take up to 4 to 6 weeks. 4 to 6 weeks to really become therapeutic and produce anxiolytic effects. So that's why we use the PRN benzodiazepine or the buspirone until these become therapeutic. So that's the concept there. All right, that's how I would approach that one. For hypnosis, I like to think about I'm treating a patient who has insomnia for different reasons. Is there insomnia because they're super stressed and anxious and then their mind keeps running that they can't help themselves to fall asleep? In those particular scenarios, one of the drugs that may be beneficial because it has very profound anxiolytic effects is going to be benzodiazepines. Benzodiazepines. And in this particular situation, there's two. Lorazepam is going to be one, and Temazepam. And I've been very fond sometimes of Temazepam. I think it's very effective. But again, one of the things that you have to realize here is that these have a high abuse potential. The people can become dependent upon these. And then if you discontinue these medications, they can develop rebound insomnia. So that's a really, really important thing to think about. All right, what if a patient has mild to moderate insomnia, but it's not stress and anxiety related? In that particular scenario, your Z drugs. Your Z drugs are going to be great in this particular scenario. So the Z drugs would be the options I would consider. And that would be the Zolpidem, the Eszopiclone, and the Zaleplon. With a little caveat here that I prefer the Zaleplon. Zolpidem, Ambien, is going to be the most commonly utilized one. But I like Zaleplon because one of the cool things about this drug is it has a short half-life. So if you give this drug, it'll really help to induce sleep, and it won't last super long, so there's a lot of residual side effects when you wake up in the morning. And so that's really one of the beauties behind this drug, is that it decreases the residual drowsy kind of nature that you have in the morning with some of these other drugs, such as Zolpidem and Eszopiclone. Don't get it twisted though, these things do have abuse potential, just nowhere as much of the abuse potential as compared to benzodiazepines. And so just do realize that it used to be thought that these do not cause abuse. These do have a sense of abuse and dependence, and if you stop taking these, you can develop rebound insomnia. All right, next thing is sleep induction. For sleep induction, so it's not really a hard time of maintaining sleep, I just need to fall asleep. And so this really is going to be one of the particular drugs that increases the activity of melatonin. So melatonin containing drugs, so this is actually going to be my melatonin agonist. My melatonin agonist. And you guys remember what this one is? This is your Ramelteon. Ramelteon is the particular option here. There's still uncertainty of the suvorexant, which is the orexin antagonist, but there may, plus or minus, we're going to put plus or minus the orexin antagonist. We just don't know enough about this drug category yet. Okay? All right. So we got stress anxiety, benzos. Mild to moderate insomnia with no stress or anxiety relationship, Z drugs. Zaleplon, probably one of the best ones without having a lot of residual drowsiness and cognitive dysfunction in the morning. Both of these have abuse potential. This one, high abuse potential. This one, just a little bit more abuse potential. I mean, a little less abuse potential in comparison to benzos. Sleep induction, melatonin agonist is definite, but orexin antagonist, not enough information on just yet. The last one is the patients who have a lot of depression-related anxiety. Depression, anxiety, but particularly more depression-related insomnia. In this particular situation, I would go with the drugs that have antidepressant functions. Ones that really jack up the serotonin, but also block the histamine action. And so this is where I would use particular drugs such as Doxepin. Doxepin would be one, that's the tricyclic antidepressant. I would also go with the Mirtazapine or Trazodone. And these all will do what? Help to increase serotonin, but also block the actual histamine. One of the beauties behind these particular drugs is that there really is no abuse potential. So with these, there is no true abuse that you should see with these. And that's really what makes these preferable. So if a patient maybe has depression, or maybe even some degree of anxiety-related insomnia, and they have a history of abuse, don't give them benzos, don't give them Z drugs. Consider something like this, which has the ability to not cause abuse, but will have anxiety and depression-related effects and treat the patient's insomnia via histamine blocking effect, via melatonin agonist, orexin antagonist effect, via GABA, increasing GABA activity, increasing GABA activity. Which one do you notice that is not on here? The barbiturate, because it'll kill you. Okay, don't use it. That covers the approach. Let's now really quickly go through the adverse drug reactions. All right, guys, so now when we talk about adverse effects of anxiolytics and hypnotics, the big thing that I really want to focus on is the benzodiazepines and the barbiturates. Not so much the melatonin agonists, not so much the SSRIs and SNRIs, because we'll talk more about antidepressants when we get into that pharmacology lecture, talking about all the different types of antidepressants. But when we talk about melatonin agonists, if there really was one big thing, it's been shown to potentially increase prolactin. So you may see some gynecomastia in males, some menstrual irregularities or lactation problems in females. That's really about it. For the Z drugs, I think it's important to remember that they again have abuse potential. They used to think that they did not, but they do have abuse potential. But if I were to tell you the degree of dependence or abuse potential compared, it would go Z drugs is the least, then benzos, then barbiturates have the most abuse potential, okay? The other thing is we don't know a lot about the orexin antagonist. There may be some type of suicidal ideation and cytochrome P450 metabolism, just not enough info on that. And again, we're not going to talk a bunch about the antidepressant drugs because we'll talk about those when we get into the antidepressant section. So that deserves a really heavy conversation on barbiturates and benzodiazepines. The whole purpose of this adverse drug reaction is to really kind of show you some of the negative connotations of chronic benzodiazepines and then why we avoid barbiturates. So when you look here, this graph here is really just giving us a degree of CNS depression. That's really all it's telling us. This is telling us the degree of CNS depression. So with some people, right, you may just want to be able to reduce their anxiety, put them to sleep, make them kind of cognitively unaware of what's going on. So kind of just depress their level of consciousness, their sensations, their movements. Some you actually can take away their ability to breathe and augment their heart rate and blood pressure. Or some you put them into a coma. Here's the big thing. With benzodiazepines, they have CNS depression, right? But if you compare it to barbiturates, which is here in blue, look at the barbiturates. The barbiturates have no ceiling effect. There is no ceiling effect. There is no ceiling for barbiturates. And there is an eventual ceiling for benzodiazepines. They usually kind of top out at not having much more than just mild medullary depression. So with that being said, if you were to think about this with benzodiazepines can have CNS depression, but we'll give it 2 arrows. Barbiturates, these things have a massive amount of CNS depression. And that's a really, really important thing, because that's another reason why we don't really use barbiturates for anxiolysis and hypnosis, is because just a little bit of a higher dose, you get an anesthetic, medullary depression, and coma effect. That's why barbiturates are more commonly used for patients who have seizures, right? So we'll treat seizures, so anticonvulsant type of activity, or you can use it in anesthesia like thiopental, or putting a patient into a coma because of seizures or high intracranial pressure and you want to kind of decrease their ICP. Otherwise, we don't really utilize barbiturates because, again, you can see the toxicity from their CNS depression. Not as much so with the benzodiazepines. The next thing that I want you guys to understand is dependence and tolerance. So dependence, again, kind of is the basic that when you have these patients who take benzodiazepines, right? So benzodiazepines who take barbiturates, and the last one is the Z drugs. So barbiturates, benzodiazepines, and then the last one is your Z drugs. When we talk about these, the basic concept of these is that barbiturates, if you give these, again, they'll help to be able to act as a GABA agonistic activity. But with continual usage, what may happen is they may develop a sense of tolerance, where the same dose maybe not produce the same therapeutic effect. And then what happens is you have to increase the dose and increase the dose and increase the dose to get that same effect. And so with that, we see the highest degree of tolerance or dependence with barbiturates. Then we see the second most dependence and tolerance with benzodiazepines, and then we see the least amount of dependence and tolerance with the Z drugs. And that's a really, really important concept to understand, is that with giving these drugs, if the drug dosage is having to increase to meet the same therapeutic effect, that's a concept of tolerance. And if you were to remove these drugs, so then if you were to discontinue any of these drugs, the patient would develop a rebound effect. In other words, if you stop barbiturates for a patient who's having seizures, you abruptly stop it, they'll start having breakthrough seizures, right? If you stop benzodiazepines for hypnosis and anxiolysis, then you're going to have them have problems with anxiety and breakthrough insomnia. If you're using this for insomnia and then you discontinue it, again, they will develop rebound insomnia. So that's an important effect thing to understand. The next thing is drug interactions. All right, so the phenobarbital, all right, and pentobarbital and all the barbiturates are very powerful cytochrome P450 inducers. And I think that's, again, another reason as to why to avoid these drugs. So they have the ability to bind onto the cytochrome P450 system and increase the activity of this enzyme. If this basically increases the activity of the cytochrome P450 enzyme, it takes a drug and breaks the drug down more. And so you'll basically enhance this pathway. You'll stimulate this pathway and put it into hyperdrive. And what you'll do is you'll decrease the efficacy of other drugs. And so that's one of the really nasty things about barbiturates, is that they cause a lot of drug interactions and decrease the concentration and efficacy of other drugs. Makes them subtherapeutic. That's a really bad thing. All right? So again, to really highlight the reason why we stay away from barbiturates is because they have massive CNS depression. They have a high degree of dependence and tolerance, and if you discontinue them abruptly, they can develop a very profound rebound effect. And they have very significant drug interactions by acting as a cytochrome P450 inducer and producing subtherapeutic drug levels of other drugs. what's the last thing that I want to talk about? And that's really the overdose and withdrawal factors. So the last thing that I want to talk about here is overdoses or withdrawal. And really, I want to spend some time talking about more specifically the benzodiazepines. All right, and the reason why is, again, we shouldn't be utilizing barbiturates for anxiolysis and hypnosis, right? We would use benzodiazepines though. And this again tries to highlight that yes, barbiturates are super toxic and we try to avoid them, but you should also be very careful with benzodiazepines, and this is the reason why. We know that it has mild CNS depression, a degree of dependence and tolerance, right? So that's one particular thing, has a potential for abuse and rebound effects. But the other thing is that you can easily overdose on this. So if a patient overdoses, they take too much, right? So they become dependent or they become very tolerant to it. They keep increasing their dose, increasing their dose, increasing their dose to get the same therapeutic effect. And then what happens? Well, then they start kind of shutting down their limbic system function. They start shutting down their reticular formation. These patients can literally start to have a very significant decline in their level of consciousness, right? So they could actually have anywhere from a point of maybe anxiolysis to actually sleeping to actually kind of being in a anesthetic state to almost being into a comatose state. So that's a really big thing. They can also depress their effect on the heart. So they could even cause maybe a small degree of bradycardia, a small degree of hypotension. But here's the most profound one. They cause a significant respiratory rate and depth depression. So they significantly depress the respiratory system. That's the big things here. Don't worry about this part and this part. But when a patient overdoses and they take too much of a benzodiazepine, one of the very scary features is significant CNS depression, right? So loss of consciousness, as well as hypotension, bradycardia, and respiratory depression. So they may become apneic. If that's the case, how do we treat those patients? We want to reverse the effect of the GABA agonist. So I want to give a drug that acts as a GABA antagonist. And the drug that I really want you guys to remember that is useful for the benzodiazepine overdose is called flumazenil. Flumazenil, okay? Now, in the same concept, if a patient is taking benzodiazepines for insomnia or taking it for anxiolysis, right? Or maybe even for seizures or for muscle relaxant activities, because there's so many different functions of benzodiazepines, right? But if it's taking it for those reasons, all of a sudden you abruptly discontinue taking the benzodiazepines. They can potentially go through withdrawal because they develop a rebound effect. So then it's opposing all of these actions. You go back into the whole anxiety response. So they can actually develop potentially anxiety, rebound anxiety. The worst case scenarios, they can even develop seizures. This is a scary fact, right? They can also develop an increase in their heart rate, an increase in their blood pressure, so they become tachycardic and hypertensive. They also can increase their respiratory rate and depth. They can also have diaphoresis, and they can have tremors. If all of these things are present in a patient who just discontinued their benzodiazepine, guess what? You probably should give them the benzodiazepine back and then start slowly tapering down the dose. Don't just abruptly discontinue it. Put them on a benzodiazepine and then slow taper of the benzodiazepine. So that's where we would do a taper. So we would taper the benzodiazepines, such as Lorazepam or Diazepam is the preferred drugs. But those are the concepts that I really want you guys to understand with anxiolysis and hypnosis. Again, going over the whole pathophysiology of it, I think it's important to know the neurotransmitters that are problematic. Then using the mechanism to understand I just have to oppose the pathophysiological process. So you do the opposite of the pathophysiology, increase serotonin, increase GABA for anxiolysis, right? If for insomnia, I have to increase GABA, increase melatonin, decrease orexin, and decrease histamine. And then talking about the approach, understanding in a patient who has acute anxiety versus chronic anxiety, which drug is preferred. And then a patient who has insomnia, depending upon the type of insomnia and the type of treatment that you want, you determine the type of drug. And then again, overarching theme here is barbiturates are a no-no, and this is the reason why. Benzos are also ones that have very significant abuse potential too. And this is kind of, again, showing you guys how to recognize that. And again, worst case scenarios if they overdose or they withdraw, how to be able to recognize that and treat that. All right, let's do some questions and put all this together. All right, my friends, let's do some questions here to kind of recap everything we talked about with anxiolytics and hypnotics. So which of the following statements is correct regarding benzodiazepines? They directly open chloride ion channels. So I would say that again, they work via the GABA-A receptor, right? So they actually bind to the GABA-A receptor. Whenever they bind to the GABA-A receptor, that actually will open up the chloride ion channels. So I wouldn't say that they directly open the chloride ion channels. They have to bind to GABA, change the shape of the actual GABA protein to open up that channel. So I wouldn't say directly. Benzodiazepines show analgesic actions. No, not necessarily. At very, very high doses, as we talked about, they can have a slight anesthetic function, especially midazolam, but it doesn't mean that they actually can remove pain. So I would not say that they have a complete analgesic action. Clinical improvement of anxiety requires 2 to 4 weeks of treatment with a benzodiazepine. You can actually experience it immediately, the anxiolytic effect, depending upon the appropriate dose. And all benzodiazepines have some sedative effects, absolutely. When you think about benzodiazepines, they have the ability to kind of reduce your reticular activating system, to reduce some of the cortical activity, so they can really kind of activate a lot of GABA kind of activity in multiple different kind of central nervous system structures, which definitely can reduce the level of arousal and wakefulness, and that's really, really very common with all of these. So I would say definitely are going to have some sedative effects to them. Which of the following is a short-acting hypnotic? So when we talk about hypnotics, we have drugs that increase GABA, right? So do any of those increase GABA? Absolutely. Phenobarbital does, diazepam does, chloride diazepoxide does, and triazolam does. So then it comes down to which ones are short-acting. So for the barbiturates, it's ultra-short-acting, and we said we don't even use these anymore, but it's thiopental. And then you have, as you go a little bit further down towards like the kind of long-acting, you get to phenobarbital. So in this particular situation, I would say that phenobarbital is a super long-acting one, so I can't use that. Diazepam and chloride diazepoxide are long-acting benzodiazepines, so that's not the answer. And then triazolam and midazolam are the shortest-acting types of benzodiazepines, so I would say triazolam here. Which of the following statements is correct regarding the anxiolytic and hypnotic agents? So diazepam and phenobarbital induce the cytochrome P450 system. Phenobarbital definitely is a cytochrome P450 inducer. Phenobarbital is useful in the treatment of acute intermittent porphyria. Actually, it's contraindicated in porphyria. Okay, phenobarbital induces respiratory depression, which is enhanced by the consumption of alcohol, 100%. So if you take phenobarbital, which is a CNS depressant, plus ethanol, which is also a CNS depressant, you'll definitely cause respiratory depression, and that's a really, really nasty kind of effect there. So absolutely. And buspirone has actions similar to those of benzodiazepines. I would say not necessarily. It can treat anxiety, not acute anxiety, but more chronic anxiety, and it works via the serotonin agonist activity, not a GABA activity. All right, so phenobarbital definitely with ethanol will cause massive respiratory depression. 45-year-old man injured in a car accident, brought to the ED, blood alcohol level through the roof. Hospital shows a prior hospitalization for alcohol-related seizures, unfortunately. His wife confirms that he has been drinking heavily for 3 weeks. What treatment should be provided to the patient if he goes into withdrawal? So this is alcohol withdrawal. Alcohol withdrawal seizures are treated the same way that you would treat kind of like in these particular patients. When you have a patient who has alcohol withdrawal seizures, there's 2 particular options, barbiturates and benzodiazepines. Those are going to be the anticonvulsants that we talked about in the anxiolytic hypnotics that only have anticonvulsant activity. There's been studies that show that phenobarbital is way superior to the benzodiazepines, but benzodiazepines are other options that you can consider. Lorazepam, diazepam, those are particular options. So in this particular scenario, lorazepam would be the best option. All right. 36-year-old male patient reports difficulty falling asleep for the past 2 weeks, but needs to be able to get up early in the morning, 6 a.m., and doesn't want any daytime sedation. Which medication is best to recommend for the treatment of insomnia? So you want something that's going to be quick to induce sleep, but it won't kind of like linger around in the morning. So in other words, its half-life's short. So Temazepam is kind of like somewhere between kind of a intermediate acting, so it'll last a decent amount of time. Lorazepam, that one's also kind of on the longer side. Buspirone doesn't really have any type of hypnotic functions. Zaleplon is definitely going to be the shorter acting one. This is great for sleep induction, and then it won't linger around and cause a lot of daytime somnolence. So Zaleplon is definitely going to be the best option in this particular scenario. So I would go with that one. And that is, again, one of the Z drugs. Whereas these ones, they're going to have a little bit more of a lingering effect in the morning, especially Temazepam and Lorazepam. Buspirone's not even a good option. 45-year-old woman reports daytime anxiety about work and family problems causing difficulty in functioning and participating in normal daily activities. Which of the following agents has a rapid anxiolytic effect and is best for the acute management of her anxiety? That's always benzos. Benzos, and then for chronic, it's SSRIs or SNRIs, right? Or potentially buspirone is the other option here. So I would say in this particular scenario, it's going to be a benzo first, and then later you can start adding on something like this or this or this. So Lorazepam would be the best option here. Okay. Which of the following sedative hypnotic agents utilizes melatonin receptor agonist as the mechanism of action to induce sleep? All right, so we need a melatonin receptor agonist. This is usually Ramelteon or this other one called Tazimelteon. They're the same thing, but these would both be your melatonin receptor agonists that help to induce sleep. So they're good for sleep induction. So Tazimelteon or Ramelteon would be the best option here. 50-year-old male presents with insomnia, not responsive to sleep hygiene interventions, has a long history of alcohol and opioid abuse, so he has abuse potential. He has been successfully sober for 10 years, congratulations, but is very concerned about future addiction and dependence, rightfully so, which is appropriate to address insomnia and minimize the risk for dependence in this patient. Stay away from benzos, stay away from barbiturates. Those are going to be the particular options here. And as I told you before, they used to think that the Z drugs did not have as much dependence and tolerance and withdrawal symptoms, but they do. They're nowhere near, they're not as severe as benzodiazepines and nowhere near as severe barbiturates, but they're still there. So I got to get rid of the benzo because that's not a good option for me. I got to get rid of the Zaleplon and the Zolpidem because those also are Z drugs. They have addiction potential. Not as high as the benzos, but they have addiction potential. Doxepin is a tricyclic antidepressant with antihistamine activity. So therefore, this would actually be a drug that I can use for depression as well as treat the patient's insomnia. So this would be a lot safer and there's not as much dependence and tolerance and withdrawal symptoms from this. So I would go with Doxepin, which is a tricyclic antidepressant. Again, you could also consider other options like Trazodone or Mirtazapine, which is one of those atypical antidepressants as well. All right, so Doxepin would be the option here. 68-year-old female patient is demonstrating signs and symptoms of insomnia, especially difficulty falling asleep. She's afraid of taking medication that can negatively affect her memory and concentration as she's still working as a bookkeeper. She's been taking Temazepam, for the past 4 days and has noticed memory problem and would like to discontinue it, rightfully so. Which medication is appropriate to treat the insomnia and minimize the risk of cognitive impairment? Stay away from benzos, right? That would be the particular best option, and probably even stay away from some of the Z drugs too. So I would stay away from Zolpidem. I would stay away from Alprazolam because that's a benzo. Diphenhydramine, this is not used for sleep. It's the adverse effect, unfortunately, of the antihistamine that you can use for allergic reactions. So this is not a preferable agent. Ramelteon is a melatonin receptor agonist that was very helpful for sleep induction 30 minutes prior to going to sleep. It doesn't have a lot of that residual type of cognitive impairment in the morning and dependence and problems like that nature. So Ramelteon, which is a melatonin receptor agonist, or Tazimelteon are going to be good options here. All right, last question. An 18-year-old woman admitted to the emergency room after an accidental overdose of Alprazolam. She's unconscious, not considered a regular user of any medications or illicit drugs. Which treatment would be used to reverse the effect of the Alprazolam overdose? So a benzo overdose, they'll have a depressed central nervous system to the point of maybe where they're lethargic to they're almost in a comatose state. They also will have maybe hypotension, bradycardia, and respiratory depression. So flumazenil is the benzodiazepine antagonist in this particular scenario. So I would give them flumazenil, not diazepam. That's just going to make it worse. Not Ramelteon. It's going to do nothing. And naloxone is for opioids. So flumazenil would be the preferable agent here. All right, my friends, so that covers all the questions related to anxiolytics as well as hypnotics. I hope it made sense. I hope that you guys enjoyed it. And as always, until next time.